Greetings, everyone. My name is Matt Provencher from Vail, Colorado, and it's a great pleasure to present a panel discussion on interdisciplinary treatment on patient evaluation and maximizing rehabilitation for the throwing shoulder in 2021. I've got an outstanding panel to join us today, and these are the best of the best in their field. And we really look forward to an interactive discussion, panel, and case-based format to help you learn what's going on in the throwing shoulder in 2021. First, we're going to have Chuck Thigpen from Greenville, South Carolina, update us on the thrower's shoulder in 2021 and what he's doing as state of the art. This is then going to be followed by Buddy Savoie out of New Orleans, Louisiana, talking about his shoulder exam and pearls to make this easy. Number 3 will be the overhead throwing athlete that I'll talk about a non-operative case in terms of scapula work and other conditions. Then we have Heinz Hoenecke out of San Diego, California, talking about the overhead throwing athlete of case treated surgically. We'll then have Jan Fronek, also out of San Diego, California, talking about the overhead athlete with shoulder instability. And then we'll wrap it up with a panel Q&A. We look forward to a great instructional course.
Thank you, Dr. Provencher. I look forward to sharing evaluation of the throwing shoulder in 2021. And I want to just share 5 questions to guide your exam. First, you need to recognize my partners, and we've really built this. This is really 15 years of working with great folks at the Stebbin Hawkins clinics, and really reflect the work we've done together, some of those that are here on this panel tonight. So the first question you have to ask yourself is, who's the athlete? Before you sit down and evaluate the athlete, understanding that it's usually not a one-time issue. Most throwers have an ongoing issue, in particular with valgus extension overload, whether it's ulnar neuritis or even the dreaded anterior shoulder pain. That is likely something that came on. When we see in professional throwers that actually most of these pitchers report a decrease in performance in the prior year. So really asking a good question. And then as the video shows, really understanding maybe who are the other factors that might influence. Some of us aren't cut out to be athletes, and that's why we're surgeons and therapists, because we weren't quite the athlete we hoped to be. But really understanding, are they specialized? There's a lot of work in other literature, and some of this is out of Little Leagues in Greenville, South Carolina. We've recently published in Journal of Athletic Training that shows while if you ask a kid of, hey, are you specialized? Are you multi-sport? Oh yeah, we're multi-sport. We know we're not supposed to be specialized. But actually, when you dig down and actually qualify them by what they actually do, they actually specialized in baseball and they just overtrain about 30% of the year. And so what it actually means is those kids that are continue to do pitching lessons and play are actually the most at risk for injury. Actually, it was almost 4.5 times increased risk of missing time as a little leaguer for elbow and shoulder pain. And in particular, if they were doing additional training. So I think understanding upfront who's your athlete and kind of what's been going on with that kid. And baseball is probably the worst of our sports of overtraining. And then I think it's important to remember, I think sometimes just because we have a hammer, we like to use it. And in particular, they come in and there's a lot of pressure. Oh, we need an MRI. We need to get imaging. And it's probably the worst thing you can do unless there's indications for it. And I would suggest that is will the MRI change my plan? Now, I'm in a different position than our surgeons here on the panel is I can't order an MRI, so it makes it really easy for me. But I think being able to understand that almost half of professional pitchers display irregular or something that would be read as a pathologic finding on an MRI is really concerning. And so if one of the things I've heard Dr. Andrews says, if you want to find a problem in a throwing shoulder or elbow, just get an MRI. And I think that's important of understanding who your athlete is and really how you're going to use the tools in your toolbox. And so for me, I think it's really important we first focus on the physical exam. And so 3 questions we're going to ask in the physical exam. First, are these range of motion deficits or differences? And these are sort of the classic numbers from the literature from work we've done and others, Kevin Wilk and the group in Birmingham. It really helped us understand that deficits or differences side to side in the 10 to 15 degree range seem to be what are associated with shoulder injuries. But I want us to think about, are they really predictive? Is that really a problem? And so if you think about all the way back to the beginning when Dr. Burkhardt and Morgan and Kibler started to teach us about it, actually, it was all in injured individuals. It wasn't in healthies. It was an injured. And actually, Tim Tyler in his AJSM paper, where he began to look at crossbody, said, actually, GERD's a symptom and an impairment, not a diagnosis. And so I want us to keep that in mind, because actually, if you look at progressively over time, actually in the Cowboys Companion, Dr. Burkhardt says that there's an acceptable level of GERD. Well, what do we mean? What do you mean acceptable? Actually, it's common in overhead athletes. Actually, 30 to 40% of healthy pitchers display some degree of GERD. And actually, we've shown, and others have shown, it's transient based on when you're pitching and timing in the season. So I think we have to be really careful of throwing a diagnosis of GERD down when actually it's just an impairment. And we've actually done 2 different systematic reviews, partnering with some folks at the Duke Physical Therapy Department. And first, it didn't predict UCL injury in any population. So we did a meta-analysis. We combined all the literature that was out there, and there was no degree of range of motion in anything, total arc, cross body, internal rotation, external rotation, that was associated with UCL. Now, there was an association of total arc and internal rotation independently in adolescence. So that's interesting. Potentially, in some population, it's helpful, but not all the time. And so there's not a true fast rule with range of motion that we can use. And so we have been fortunate to work with a single organization for 10 years. And we've just finished a multivariate predictive analysis where we took all the factors together. So the issue with baseball research to date, we keep looking at just range of motion. And right, we wish it was that simple. If it was just GERD, we would have already fixed this. We've been doing sleeper stretch and crossbody and all kinds of treatments for GERD for 20 years. If that was a problem, we would have fixed arm injuries. And last time I checked, arm injuries are still going up in professional baseball. And so we set out to look at consistent, these are all factors that we look, some modifiable, some non-modifiable, to really consider a multivariate model that allows us to say, hey, is there a safe zone, i.e. a normal amount of adaptation that allows you to participate, and is there a range that puts you at injury risk? And what was really interesting when the model came back, 3 things popped out, and you'll notice the one thing missing. Range of motion did not carry through into our model. It did make it through the first phase of statistics to actually be carried forward into the final predictive model. So range of motion, 10 years of data, 2 therapists, one of which I was, measured every single shoulder. We measured the athletes. We followed them in one organization in the HID system, and no association with range. Shoot. But it is interesting that what we begin to see is actually there were some safe zones, i.e. a certain amount of pitching that seemed to be safe in terms of exposure. There's a certain amount of torsion that seemed to be safe. And guess what? Bigger guys, you draft the linebackers and they throw harder. Those guys tend to be at increasing levels of risk. And so this graphic really shows us what we see in humeral torsion. This is an injury log. The higher the curve up, that you're more likely to get hurt. And what you see is if we plot the side-to-side difference in humeral torsion, there's a peak over here on the left. These individuals on the left tend to get shoulder injury. They don't have as much side-to-side difference. There's a sweet spot in the middle. And then if you have too much, you tend to get an elbow injury. So we feel like that's an interesting thing with torsion, and likely influences and may actually explain the adaptation of the soft tissue. So I look forward to hearing thoughts from our panel. The next question to ask is there enough muscle performance to pitch? It's really simple, right? It's, are you strong enough and have enough endurance to do that? So for me, I like to look at 3 things. You see the upper extremity closed kinetic chain. I think it gives you a great way to check muscle endurance. 66, 90 taps within a minute. George Davies has described this and validated it. This is the prone endurance test. It is a simple test to use 3 to 5 pound weights to check the posterior cuff. It allows you to see, can they use their scapula together with their posterior cuff? And then if possible, using isometric shoulder tests, using Biodex or a handheld dynamometer. But I really like these bottom 2 because you can do them anywhere. They're very low tech. It doesn't take a lot of equipment to allow me to understand that. When we think about muscle adaptations, We also think about scapular adaptations. Dr. Kibler's taught us to look closely. But what I want you to notice here is on the left is a picture in preseason. Also, I had a lot of hair at that point. And on the right, you see this individual, and he actually shows up and begins to display some dyskinesis. And we're going to talk about this later with Matt. But what's interesting is actually for this individual, he threw 100 miles an hour that night. And his adaptation was not his scapula. It was really just the scapula waving at him because he had a dramatic change in his range of motion. So I think understanding that there's an interaction and interplay between the available range of motion and the muscle performance to handle that range of motion. That's really the question as clinicians that we have to evaluate. So the other things that I like to look at are the kinetic chain, making sure, can I tie it all together simply using a squatting? So you can do it with a plank or without. Can they really fold up their kinetic chain? Can they perform a single leg squat? It might be the single best performance related to pitchers there is. Super simple to do. Can they do a side plank? Can they go up and really hold? Can they use that lateral core? And then do they have the available trunk range of motion? Each of these things allows me to understand, are they able to use their kinetic chain in this violent rotational sport? And then the last thing is their loading matched to their capacity and tolerance? And I don't get too technical here. It's pretty simple. This is Aroldis Chapman throwing 106 miles an hour. And that gives us a certain pitch count, but there's a load that comes on that, right? There's a certain load that all of us experience when they do that. Typically what we do is just count number of pitches. We get fancy with cameras and loading, and we say, well, the external load that's going should match the internal. But we all know that pitchers respond differently. There's a lot of work in soccer and other sports that talk about a gradual amount of loading and likely a sweet spot of gradual loading. So really thinking about the number of pitches, and then just simply how hard is it? Hey, last time you pitched, scale to 0 to 10, was it easy or hard? And that gives you a sense of how they're really matched in their muscle performance and their range of motion to tolerate this violent sport. And I think this is probably the most exciting area for me in understanding how to get pitchers to recover and do that in this nice gradual, right? If you gradually ramp up your pitch count, that's likely why early in season, most professional pitchers do pretty good. And then they hit go and they get in trouble. Why? Because they have a big outing. Maybe they pitch a complete game, they take a break, and then they come back. But I think that's important to ask as we get ready to return these pitchers back. And so pitchers begin to train, right? They do lots of crazy stuff. And so this was just easy stuff that you can find on the Google machine of weighted balls and other things. But I think what we see is it's probably not the appropriate amount. It actually kind of drives me crazy because what we know is doing a heavy weighted ball program actually changes your mechanics in a negative way and doesn't increase your ball velocity in a meaningful way. And recently, Mike Reinhold and the guys out of Boston actually showed that it doesn't get a meaningful increase. You get some maladaptive changes in range of motion and strength. And actually, all the injuries they've seen were in that. Now, the caution is it wasn't the purpose of the study, but actually they've continued it and they're seeing the same trends. And this is, I think, what a lot of us see in clinics. So understanding not only we get them through, hey, here's your plan, and we need to cement this as you go out. And so likely a scalable injury reduction program is how to consider. This is a program we use. It's in review with AJSM. We're hopeful it's kind of ready to be published now. And really, that's simple stuff, right? It's back to the basics, very similar to our throwers 10 on a regular basis with some stretching, seems to keep arms healthy. And so really looking to do that allows us a scalable way to do it. So I would just end with a few questions for our panel is really, and we'll just kind of go around the horn. Buddy, you see as many throwers in the southern area there as anybody. What do you think about in your athlete? What are the 2 or 3 questions you really like to answer when your athletes come in to understand who that athlete is?
So one is the level of play and how long do they plan to play? If I have a 12-year-old and his goal is to play in high school, it's different than a high school player who's trying to finish out high school. One that wants to play at the next level, has a scholarship already. my collegiate athletes who want to finish the season, and we're looking at academic performance and can they transfer, can they stay? And then the professionals that come in, that's mandated by the agents, and when do they have to be back? And so those injuries are all different across the board. So that's the question. And the key thing that I always ask my throwers when they come in is, how important is your sport to you? And every now and then a kid will say, I don't care about it at all. I do it to please my parents, or I'm doing it because I have to. I don't want to, and I could quit tomorrow. Then there's no point in operating on them. You can certainly rehab them a little bit and see if you can get them back, but it sort of changes your perspective of what's important to that particular athlete.
That's great. Thank you. Heinz, when you think about your experience in particular in professional baseball, what's your experience in regard to specialization and playing one sport? You've seen a ton of professional players over the years. What's their history that got them to the major leagues? They specialize in one sport, or they tend to play a variety?
Yeah, that's interesting. I'm glad you mentioned that about the kids, because it's the opposite of what people might think. It's the elite athletes in high school, especially early high school, played 2 or 3 sports, and it's the near elites that want to be elites that are overtraining and getting the extreme coaching year round, and the elites eventually take off when they go to college. They may go into one sport. I took a survey of the San Diego Padres major league team as they came off the field one time with the coaches and the players. We surveyed about 33 of them that came off that day, and the only ones that did not play 2 or 3 sports in high school were the Latin players that did not have sports in high school. So they all played 2 to 5 sports in high school. So I think that sort of tells you. And so parents, if you're in your elite, have fun and don't overtrain.
That's great. Thanks. Jan, when you think about range of motion, how has it changed for you of how you evaluate it and sort of think about what bad range of motion, or maybe something we really ought to think about versus this athlete's just changed because they play in a crazy single-armed rotational sport?
No, I think that's definitely critical, and I'm glad the way you outlined the limits of what we consider to be reasonably acceptable, good range of motion. And what else is worrisome. The other thing that I think Warren's mentioning is the fact that changes with exercise. So, and when you're warming up, that range of motion may be one thing. At the end of the game, it will be different, much like on your video clip, they're looking at the scapular dyskinesis that comes on after the game. And it will change throughout the process. And certainly with fatigue, that's going to change the range of motion as well. So one needs to kind of keep an eye out on all of that.
That's great. Thank you. Matt, you got one thing to test muscle performance in the office. You don't get to send them downstairs. You got to convince an athlete that you don't have enough beef. That's your problem, and you got to fix that before I'm willing to entertain surgery. How do you get at that in the office?
Chuck, I think you taught me this as well as maybe Kevin Wilk, is you have to fatigue some of these folks, and you've got to put them in there, and you've got to rotate them, external, because testing it once, like we usually do in the office, or testing it maybe once or twice side to side, you're not going to be able to differentiate with that. And so fatiguing them, having them, even just setting up a band very quickly in the office and not doing all the fancy machines, like you said, you can learn a lot side to side after you fatigue some of their external rotators.
That's great. Well, I appreciate the panel, and I hope we found this successful. I look forward to the rest of the discussions. Thank you so much.
Matt, thanks so much for having me on the panel. It's always an honor to be with Heinz and Chuck and Jan and talk about the throwing shoulder. Our initial evaluation includes history, exam, and imaging. You can see unstable shoulders video, and here you see a patient with marked scapular maltracking or dyskinesia. This is a serratus dysfunction, so it can be a problem. You want to ask the patient about the onset of symptoms. Was it insidious after the game, over a few games, or was it an acute one-time throw where there was a pop or an injury? Do they have pain all the time or only with activity? Night pain is really a bad sign because that usually means there's rotator cuff inflammation or damage. strength and endurance changes, and then past treatments, injections, medicine, bracing, therapy, rest. What have they done in the past for this problem? General exam, we check posture, core, and balance. We do a one-legged squat. I think it's absolutely critical. Chuck asked on the last part of this which one test you would do, and for me, it would be that. The other would be scapular assist. This is a Whipple test. We'll show it to you again. The critical components to me is core strength. I also like to check the lead hip in a thrower for an internal rotation deficit, because if they can't internally rotate that lead hip, they can't bring the body around it, and they'll leave the arm out to dry. And then we'll harp on this a bit about the scapula. Our instability exam, we palpate for tenderness. We look for the position of apprehension. Larry Field and I described the SLAP test, which we think is pretty good. The modified DLS is important. An O'Brien test with and without scapular assist. And don't forget, you can move the shoulder back and forth and look for instability. Our physical exam in terms of the rotator cuff, think anatomy. Try to find out what hurts, palpate the tear, palpate the AC joint, palpate the biceps, palpate the pectoralis major tendon, palpate the suprascapular nerve, and see where tenderness is. Exam confounders, when you're looking at the shoulder, the AC joint, lots of people get AC separations, get a little bit of arthritis and a little bit of horizontal instability, and that can really change your exam. So we like to do the AC compression test. Biceps, if you really think there's a biceps tendonitis, do subpectoralis palpation. Adhesive capsulitis, know the inferior glide test. You'll never get fooled if you know this test. And then don't forget on your x-ray to look for lateral projection or check your critical shoulder angle. And so posture is critical for everything you do. This is my youngest son. He was a left-handed pitcher, very powerful and strong. Whipple test, very positive. O'Brien test, positive. If I manually retract his scapula, you could do pull-ups on that arm. So to do an accurate exam, you have to have a retracted scapula. Capsulitis, this is the inferior glide test. It will be painful and will not move. And if that happens, that's an adhesive capsulitis. Stop everything else and treat that first. Even if there's not a loss of motion test yet, this test turns positive. The AC joint, we talked about it. Look at it. Look at the clavicle. Try to do cross-chest adduction and flexion, and then you can compress the AC joint and you can shift it with your hands, and look how it changes just with scapular movement. Flat, prominent, and so that can cause symptoms and might be something that will cause a problem. I think palpating that posterior AC joint, just like you see here, if you feel some popping or crepitation or movement of the clavicle, you may be dealing with a horizontal AC instability, not something inside or deeper inside the shoulder. Rotator cuff tests, we all know these. We got to go back and forth on those. I like to palpate the biceps at the interval and also underneath the pectoralis major tendon. If they're tender down there, you're dealing with the biceps tendonitis. That's the only thing that actually caused that. And we can add in speed, Jurgensen, and SLAP testing. And this is our SLAP test. And you can see we move it in different positions to test different parts of that. Supraspinatus, the isolation test, and the Whipple test, we kind of go through those. For the upper infraspinatus, which is commonly involved in our throwers, I like to bring it up to about 45, push down, and then bring it back up to 90 and check it again. A lot of our throwers will have lost that last little bit, and what they'll tell you is the ball doesn't move anymore. If they don't have that infraspinatus strength, and on the follow-through, the ball stops moving, and for the higher level pitchers, that means it goes in hard, comes back harder. It's not a good thing. And then the lower infraspinatus, subscap, we all know about belly press, bear hug, and liftoff, thanks to Steve Burkhart. And then the teres minor, we can do about -30 at the side. Impingement can be anterolateral or coracoid. We've talked about that. Those are kind of classic tests. And then on our x-rays, we want to look at that lateral projection of the chromium. If you look at this picture and you start to see increased projection here, Christian Gerber has taught us that this critical shoulder angle may be important. I've had congenital acromion where they stick way out. It's not an adaptation, it's genetic. And when we get to those, really you need to do a lateral decompression to take care of that child. MRIs, the only thing I would tell you is look at it yourself. Always look at that, look at the cuff, look for impingement, look at the labrum yourself. Don't count on the reads to tell you what's wrong. So in summary, I think the patient will tell you what's wrong. Take a good history. Your physical exam confirms the history. Imaging rules out mistakes and should confirm what the history and examination tell you. Thank you.
Case presentation in the overhead athlete, Matt Provencher from Vail, Colorado. So what do we know? The scapula and the throwing shoulder is super important. And Buddy just shared the important physical exam that's part of this, not just the front of the shoulder. But we all know the scapula is probably even much more important than the front structures because it affects our ability to push, pull, lift, or perform overhead activities and even activities of daily living. Mechanically, it disrupts the scapulohumeral movement and range of motion if it's a problem. And you can get pain in the posterior shoulder or even in the anterior shoulder if you have a lot of anterior tilt and internal rotation. So just a brief review of the muscles that are affected and some of the things we need to focus on anatomically. The serratus anterior, it originates from the first 9 ribs. It passes posteriorly around the thoracic wall. It's innervated by the long thoracic nerve. We all know the acronym SALT, serratus anterior, long thoracic, but it functions to protract and rotate the scapula and really optimizes glenohumeral position during shoulder movement. It's a little bit hard at times to palpate the serratus, but you can feel it on the rib cage and you can feel it firing with scapular motion. The trapezius is also important, C1 to T12. So it goes way down. It's very broad. And the low trapezius is super important, as Ben Killer and others have taught us, which functions to elevate, retract, and rotate the scapula. And it's innervated by spinal accessory nerve number 11. The rhomboid, the function is to retract, elevate, and rotate the scapula. It is deep to the trap. It's a little bit hard to palpate, except if you're right near the spine, and it's innervated by the dorsal scapular nerve. And there are problems that you can pick up with the rhomboid quite easily, especially with certain types of winging. And so here's some clinical examples. You can see the inferior angle is really a problem here in a patient that just has very low muscle tone inferiorly. Type 2 is where the medial border, the entire medial border is a problem. So you're getting into additional muscle groups, including the rhomboid, the low trap, and also the higher trap. Type 3 is a superior border. And really, when a shrug starts, you immediately get that scapula that goes superiorly. And type 4 is just abnormal overall scapulothoracic rhythm at the end of the day. And that encompasses usually numerous type of scapula issues. What do we know about the literature? The alteration in the normal position of the scapula is really important. Chuck actually wrote on this and talked to us about scapular kinematics. And you can also get subacromial impingement syndrome. And this is also a problem. I'm going to talk about that in a little bit. And then evaluation and management of scapular dyskinesis in overhead athletes. Ben has taught us a ton on this. And the scapular plane is the most likely to demonstrate altered kinematics just in overhead workers, but also the athletes in the throwing shoulder, which we're talking about today. So here's a case of a 32-year-old male, left shoulder aching pain with activities. He actually plays in a weekend and weeknight baseball league. He's the shortstop, and he's just having a hard time getting that left shoulder to whip it like he used to over to the first baseman. And so, of course, his whole team is kind of hassling him quite a bit because he can't throw it as well. He used to be one of the best players on the team, but now he comes to you because he used to be one of the best players on this weekend warrior team. He doesn't have night pain. It's only when he's doing these activities, really with overhead, some weakness. And he did PT for about 6 weeks. So what are our options? Chuck, what do you see here? He's in your clinic. You sort of see that left side and some of the testing we're doing here. I know we don't have everything, but what do you see initially and what are your concerns?
The first thing I notice is as soon as he starts to elevate, the scapula just takes off around the thoracic wall. So he either has way too much tightness pulling him around or not enough stability, and in particular of his low trap and serratus to hold him to his thoracic wall. And so for me, the first thing I would test is really lock down his scapula and make sure his lats and teres major are able to extend. In particular, in the more mature athletes, what we see is, and you can see there, he's very well developed in his lats and teres major. And in about 30% of the population, the lat grabs onto the inferior border. And so what you see is in those folks, it actually is trying to be the scapular stabilizer, but it can't do that. And then my assumption would be is if I isolated his lower trap, he can't hold the scapula back. He can't stabilize the scapula and disassociate his arm. And I think those are the two things and it's sort of the same example that I made, is that relationship between shoulder mobility and then having that stable scapula to allow the arm to whip around, that's really what it needs to do. And so we have to tease that out in our physical exam.
Yeah, Chuck. So talk to us just a little bit about you said too much in the front, not enough in the back. So talk to us about that, yin and yang in terms of push and pull and what's going on in the front here in this patient as well.
So in these hyper-developed athletes, right, especially their pec major, pec minor, teres major, and lat, really all are those strong internal glenohumeral rotators. They provide a tremendous amount of power, but they or push forward, but they also take the scapula where we don't really want it to go, in that downwardly rotated, anteriorly tipped, internally rotated position. And so, what you tend to see in these folks is they have that pec tightness, they're stuck down, they can't control it back and elevate their arm on top of it. So you've got to really be able to address that anterior tightness with some mobility. But what I find is actually, it tends to be the lat is sort of and teres is the key to unlock it. And then the pec will begin to let go. It's the pec's just hanging on because you don't have enough. You got to hold something. You got to keep the scapula attached to the shoulder blade somehow, or to the thoracic wall somehow.
So Heinz, he actually played ball back in the day. He's 32 now, but he played, baseball, was an infielder, and he's got about a 20, 25 degree side to side internal rotation difference and a little bit less actually total arc of motion as well. He just doesn't have the concomitant external. He's a shortstop. What do you see with this, and does this concern you as well?
Well, some of these guys, they have a normal side-to-side difference. Obviously, if you have a history, if they were really playing at the level that you could actually talk to their trainer and find out where they've been at historically. But other ones, especially if they're getting older, or if they're playing less, they just get tight because they're of natural tightness. And you have to, I like to still look at the total arc side to side, and then try to work with the therapist to come up with a plan to see if we can, because they may not have been that way all the time. This can sneak up on them, sometimes even with inactivity.
Yeah, no, that's interesting. But you think you can get him even a little bit better just by improving his motion? I mean, obviously you got some scapular issues, but motion on top of it, we got to look at that as well. Jan, why do you think he has shoulder pain overhead? What is the phenomenon here? What's going on with that?
Yeah, I think good question. I think in terms of understanding the actual mechanism, I think what's happening is that basically with the scapular dyskinesis, and again, as has been brought out, that's more of a symptom rather than a diagnosis. The positioning of the scapula results in the impingement, sort of a dynamic impingement is probably going to be the main reason for that problem. And then you're irritating the supraspinatus, maybe portion of the biceps would be my working hypothesis. And that's where those, the testing that Buddy has talked about, and the scapular assistance test, I think is really helpful, whether that allows you to eliminate some of the pain or increase the strength.
Yeah, Jana, I love that. I love the dynamic impingement you describe. And, although CMS doesn't believe it anymore in terms of coding, it's a real entity. And I sort of think about it as the glenohumeral joint. Obviously, when you have micro instability or slap tears, or you get this obligate translation. Well, we're getting an obligate translation of the scapula here, and/or really a rotation, internal rotation, anterior tilt. It's just causing altered mechanics of that. So we don't really know for sure, but I really like your theory on this and buy into it. So this is it's a big problem. Chuck alluded to this. This is tight pec minor. We had a very big problem with this actually in the military. This is one of our studies we did where we looked at 46 patients that were identified with tight pec minors. They had this type 1 kind of scapular dyskinesia, plus, as Buddy talked about, tenderness in that area, go where the tenderness was. There's a lot of tenderness in the pec minor. Buddy, talk to us a little bit about this and how it affects your decision-making with some of these tight anterior structures, even though, the back doesn't look good either.
So I think you have to think of things in 3 dimensions in a global picture. And so palpating in the front, pectoralis minors like to get tight. Chuck talked a little bit about the imbalance, and Jan gave just a beautiful description. But if they're tender over the pec minor, then that means it's pulling too much. They should not be tender there. And if you go right over the top of that pec minor, you're right at the suprascapular nerve. And so it can cause positional thoracic outlet because they're trying to go up. And if it's too tight, it puts pressure on the plexus as it comes across. You can have positional complete obliteration of the pulse when they go up. So that being too tight is a big deal. And I like to do it by palpation. If I'm worried that it's a major part of it, sometimes I'll do a little Marcaine or xylocaine shot and see if it alleviates their symptoms. And then we can do the stretching. I mean, your guy said, I've done 6 weeks of therapy. Probably no one has massaged or tried to loosen up the pec minor, haven't taped the scapula back into position, really haven't worked on the things that need to work on to balance the shoulder. And he's not going to get anything back unless we stretch that pec minor out.
Yeah, I mean, that's exactly what this patient had, buddy. A lot of tenderness on that medial to the coracoid. I think back in the day, I wasn't even feeling for this. It was kind of, okay, well, look at the scapula, test the shoulder, do impingement. But this is a real deal and a really big problem. We actually found that the vast majority of these, Chuck, responded to therapy. And the 6 that did not respond, so we actually did the pec minor release, just sort of like we do in a Latarjet procedure, and the symptoms resolved very quickly. And Ben Kibler talks about these folks as pathologic, not tight. They're just pathologically tight. No matter what you do, you're not going to get them to stretch out. Now, I had a hard time figuring out, at the end of the day, who was going to be pathologically tight and who wasn't. But Chuck, what are your strategies to get the front part to loosen up?
I think the first thing is I was interested to your reading this paper is they were all heavy bench pressers, right? They kind of have a stigma and a body type. And so I think the first thing is for at least a period of time, you've got to modify their pushing and loading. And so an overhead athlete, like the case you shared, you got to give me a minute. You can still throw, actually. I'm okay with you throwing. That's not what's making you hurt. But you got to lay off the curls and the bench presses and the lat pull downs for a period of time. That's actually maybe the most important thing. And then I think coming behind with some soft tissue work, I think if it was my practice, I'm probably going to do some, get in there pretty good and pretty aggressive. You'll find folks that do dry needling. There's plenty of soft tissue techniques we can have, but I think that's only to allow some extensibility to follow up with the stabilization and mobility stuff. So you want to do that, and I would expect this individual to respond in 4 to 6 weeks. If the mobility is not improving and his symptoms don't start to die down, then I'm raising my hand saying, wait, something else is going on. And so, in this case, those would be the folks I'd be sending back to you. Look, I'm out. We've done it. That would be the truly failed non-operative approach, in my opinion.
Great. So Chuck, just as you suggested, we kind of recalibrated that rehabilitation program. And we talk about it all the time. Wow, they did 6 weeks. Do they do it right? But I think that's important. You have to spend the time with them. You get the right people involved. And so try to focus on this pain-free range of motion. We're obviously looking at the core strength. Heinz, how does this come into your evaluation in the clinic? Core strength in a thrower, even, a pretty high-end weekend warrior. And you saw his exam, but how does that play into your overall plan here?
Well, the classic one, and it's already mentioned by Buddy, is I get the 14-year-old kid who's a rising star. He's now 6'2". He grew 6 inches last year, and he's skinny. And they come in and complain of elbow pain or shoulder, but a lot of times it might even be elbow. The first thing I have him do is 5 single leg squats and watch to see if that knee dives into valgus, and then look and see from the back, also how their whole scapula is moving. But that's my favorite test. I'm with Buddy on that one.
Yeah, get them to fatigue, test it, look at that single leg and see how they cave in. They will, every single one will cave in for the most part, at least in my experience, or I'm just seeing some poor core strength throwers. So we're still kind of in this acute phase. Some of the other things we tried, although I'm not sure it was 100% worked, was Botox, other injections into the pec minor area. We did this under ultrasound guidance. I think it might have helped a little bit, or maybe help with the pain cycle. I've done Toradol in there just to help break it. I'm not sure it worked. Buddy, what do you think? Crazy?
So we didn't have any good luck with Botox. Occasionally a steroid shot just because it weakens the tendon and you work on your stretching. But I'm with Chuck. We do massage, dry needling. We'll actually do some pretty strong taping and bracing so that we force the shoulder into retraction, and that helps stretch out the pec minor. The key with those is not to go too hard, too quick. And so we'll put them in a brace. There's your taping. We'll put them in the brace and tell them 5 minutes, and then take it off, put it back on for 5 minutes when the soreness goes away, because you worry about creating more inflammation and more contracture if you do it too hard, too much. And so I think you really depend on your trainers and your therapists to work this out for you. And then you can we always show the kids how to do a pec minor stretch on the wall. So, just get on the wall, and when you come through a door, just stretch it a little bit, massage it while you're doing it. I have found that topical anti-inflammatory cream so that they can massage it into the tendon has been helpful, much better than any injection.
Yeah, no, that was exactly our learning. I don't think the Botox really worked, but the steroid wasn't bad. The pain cycle breaking type thing wasn't bad. Toradol actually wasn't bad either, but the Botox didn't work. It sounded like it should have, but it really never did. But I love all those other strategies in terms of getting this right. So anyway, we continued on the rehabilitation, and really what I tried to do is check in with this person every 3 or 4 weeks. And I found a little bit more closer follow-up, a little bit better accountability, and then progressed scapular patterns with arm elevation, more open chain. And then this kind of getting almost to the maintenance phase, because when they start doing well and passing through this, again, these weeks are just sort of made up, but they're approximates. You really have to customize this to the patient. And then getting into a throwers program, sports specific, functional testing, and then really dynamically challenging the scapular stabilizers. Chuck, thoughts on getting through this?
I loved your comment on accountability. He's lucky that his surgeon will follow up and check on him. I think that's what's actually really interesting with all the remote and camera and wearables and stuff. Is we've learned how to do virtual therapy in 2020. Is that the level of accountability? And I think in a case like this that is somewhat recalcitrant, he failed therapy before, they've got to be able to commit to sort of a long-term plan. And it's like, I'm sure other cases, SLAP and some other things that are a little bit of a long slog. Having some accountability and really staying with it is really the key, because it's not going to get better in 2 weeks or 6 weeks. Because if it was, he wouldn't have been in your clinic. He would have the general strengthening and rest would have gotten there. And so he needs sort of that longer plan. I think setting that expectation for a longer recovery period, and that's expected, and then setting that expectation. The reality is I can say that as much as I am older now. I don't have much hair. I've got a little bit of credibility, but coming from the surgeon to set that expectation, it really helps to drive home that accountability with the patient. So he was lucky to have you.
Well, it's a team effort to make this work. And in my opinion, if you just say, okay, go away, here's your therapy script. I just found that accountability piece to be very powerful. And they want to make the whole team proud, that they're going to get this better. And you tell them that you can get this better, but it's on you. You got to get this done. So we did a lot of, obviously the trap work, serratus, the rhomboids. This really comes down to understand the anatomy, know what attaches to that lower scapula, what's important. And by really took longer, than he thought, 4.5 months, but I don't think that was that bad at the end of the day for the amount of dyskinesia this patient had, the amount of tenderness in the pec minor. He was able to play a full game nearly pain-free. It wasn't perfect. By the end of the game, he was fatiguing a little bit in 8th, 9th inning. His sane score wasn't perfect, 88, but a lot better than the 59 he started at. Jan, comments on timeline? Was this something you see in San Diego and your weekend warriors post, still playing, still living the dream?
No, it's just classic case. I think all the key points have been brought out. I especially like sort of that link, and maybe we're getting into a rabbit hole, but the whole business, how this may relate to thoracic outlet syndrome. And the way our pain management people sort of screen for the thoracic outlet is with the injections around the pec minor. You always wonder how much of that may be playing a role. But I think that it's most of these guys do respond to a good rehab program. Compliance is key. And I hope that with telemedicine and some of the wearables, that compliance will be enhanced.
I should have never published that paper on the pec minor release, because now I have a whole cadre of thoracic outlet patients coming to see me for pec minor releases. But you know what? I think in the right patient, it actually works. It's the main treatment, just as Buddy said. I mean, Buddy, I think it's, you're taking out this first rib in some of these cases, maybe not us, the cardiothoracic surgeons are, but it's a very bona fide, true and tested treatment. Buddy, thoughts on that?
No, I think you have to differentiate positional thoracic outlet, which is related to dyskinesia in a tight pectoralis minor, from true thoracic outlet, which is scalene in first rib. And so most of ours that we see are positional thoracic outlet. And a pec minor release in those patients that fail physical therapy is a lot less morbid than taking out their first rib or cutting their scalene muscles, or both. I think it's a very reasonable way to go. I know, I can do it from the top arthroscopically. I don't dissect out the plexus like Thibault Lafosse, but it does decrease the pressure. And the most simple test is put the arm at 90-90. The pulse will go away. If you stabilize the scapula, the pec minor continues to do pressure, the pulse will continue to go away. And then when you release it, you put them in that position and the pulse is back. It's all good. I think it's a very reasonable procedure.
Great. Well, I want to thank the panel for an excellent case, and we'll move on to our next one. Thank you.
Thanks, Matt, and thanks for this opportunity to everybody here today. My disclosures are online, and also nothing relevant for this presentation. I wanted to cover a case study to promote some discussion, invite everybody's comments. This patient is a 19-year-old quarterback. He's had about 2 years of pain. He's been continuing to throw, continuing to play at a high level, but he gets posterior shoulder pain, feels unstable. He feels like he can't train well anymore. He has trouble getting his strength back. He actually has a loose shoulder also on the left, so it's difficult for comparison to the right, and that shoulder has problems also. On examination, he's had a positive O'Brien's test. He's had some mild pain with hyperflexion, negative apprehension test on the right. I have a question for Buddy on this. When examining these throwers, and especially a lot of baseball players, I know they have a posterior instability, posterior labral test, posterior labral tear. And some of them have pain with O'Brien, some of them in the throwing position, late cocking. Sometimes the pain goes in different areas. I found a very varied presentations on these. Do you try to seek out a classic presentation, and how do you account for the variables?
I think these patients are kind of all over the place. When you think about it, what we try to do is a modified DLS for the posterior superior labrum with and without scapular retraction. I think that makes a difference. We do the O'Brien test similarly with and without scapular retraction. The apprehension test the same. And then what I tried to show at the beginning was just trying to shift, and put my hands up, shift the head into areas so you'll kind of fulcrum around and see where they become symptomatic. And the key is they're going to be symptomatic at rest in certain spots. And if you retract them and the symptoms in some of the places go away, then those are secondary. The one that doesn't go away is the primary. So if the DLS is positive, and it's positive even with scapular retraction, you're probably dealing with a posterior superior slap. If the anterior apprehension is positive, but then you retract their scapula, do it again, and it's negative, then that is secondary. What Matt used the term micro instability, but it's secondary anterior subluxation to the fact that the break in the ring is posterior superior. So I think when you put those things together, then that lets you know where the primary pathology is. Because in someone like this that has laxity on both shoulders, you only really want to fix what's causing him to not be able to be a quarterback. And so for what you're saying, it looks maybe more superior posterior than anterior, even though the anterior apprehension is also there. It may just be in one spot, and that's all you want to fix.
Thank you. Chuck, do you have any comments? And when does this guy come to surgery for you?
This is thanks for having an easy case. I guess that's why you brought it up. But I think this is definitely a challenging one. I think Buddy's key point there in terms of teaching him to be asymptomatic. So I would take Buddy's exam findings, and I'm just going to make the assumption that with a centering of the head would reduce his symptoms. If that's the case, that's the individual that I can teach his cuff to work in balance. And you have to start him down low and get the pecs and stuff not to dominate and really teach him to use his cuff well. They actually do pretty well. And it's really common in our football athletes, right? Everything's overdeveloped except for their cuff. And it's amazing how you even take them and treat them like a subscap patient and have them do a belly press. Now, they don't have a tear, but they can't, you'll take a big, huge football player and they can't not use their pecs and lats and keep their hand on their belly. So it's very apparent they're not able to use the subscap, which should be the protector. So I would take them, put them in that position. If that's not their issue, though, then I get pretty worried. They're on a pretty short leash. We just recently published a paper in posterior instability in adolescent football players, not overhead. And actually, those individuals did the worst. So our anterior instability, we're able to rehab quite a bit of those non-operatively and have some pretty good success. Our posterior instability are not the ones. And I think I start to worry about this guy with some of his complaints and overhead and throwing posteriorly.
So Matt, now I'm going to throw in another fact. This athlete presents in January, and he's the starting quarterback, Division I, and he next year he's going to be a sophomore. He's already the starting quarterback. What are you going to tell him about maybe he should just fix it now, because he's struggled into the end of the season, but did well. I mean, played well, but he wants to do better next year.
Yeah, Heinz. I mean, that's he's a little bit between a rock and a hard place. And do you really hit it hard with therapy? Guarantee he's got some scapular dyskinesia. Guarantee he's got some abnormal mechanics, some core issues, other problems. Whether with or without this injury, he clearly has an anatomic lesion. The anatomic lesion in the shoulder and the MRI you're showing here is not small. It's pretty significant slap tear, biceps issues with posterior extension pretty inferiorly. So he has the real deal. He has an anatomic lesion. The problem is he's going to need time to get this better, and to get back to high-end quarterback, you really need 5-6 months. And it's not the way we're able to fix these labrums and put the anchors in and do it well, it's knotless or knotted fashion, or it's really the other things he's got to fix. And the problem is he's had this for 2 years. And so he's got to make a decision pretty quickly if he's going to play next year with a successful therapy program.
So, Jan, do you think it's a different time course for a football quarterback than a baseball pitcher?
Oh, definitely. I think that, as we know, the mechanics of throwing are very different. And I think the quarterbacks, just the fact that this guy has put up with 2 years of therapy makes him a little bit more resilient. I would be a lot more optimistic about his outcome than in baseball. But as Matt says, I think it's correcting the anatomic abnormality is one thing, and then correcting all the dynamic stabilizers and so on is a key aspect of it. Let me change gears a little bit and put it up for the rest of the panel. What do you guys think is the role of bracing in this setting, or those posture shirts? Do you find that valuable at all, or is that just part of the business side of things that's pretty useless? I guess, Buddy?
Yeah, so I like to use bracing and taping. I think it makes a difference. Actually buy posture shirts for every one of my Tulane baseball players. I don't know how much they wear them. The trainers try to get them to wear them, but we try to keep them in it for practice and games. I think it makes a difference. The other thing for Heinz is that for our football players down here, it may be different in California, but that 7-on-7 season in June and July is hugely important for high school quarterbacks. And so it used to be we could get them ready for August 1st and the coach would be happy. Now it's, I need him June 1st. So it's really changed the timing. So, with high schoolers, you're always looking at timing, and, you brought in January. So part of it is you're thinking you have 8 months, and we don't. We actually have till June. So you have 5 months. So we need to make a decision pretty quickly on this shoulder if you think it's operative in this particular case.
All right. Thank you. So the tear started at the biceps labral anchor and extended posteriorly to the equator. So it goes pretty far back. And as Chuck showed, that the tears are not uncommon in overhead athletes. And so I'm going to expand out from this a little bit and talk just about slaps and the big picture from the bigger viewpoint. So this is just my opinion, and I'm inviting you guys to jump on this and sort this out. So when I say typical slap, I mean the one we find in an overhead athlete, a Major League Baseball player, or somebody that is degenerative slap, just older patient. I think just about everybody over 50 has what we could call a slap, degeneration of the superior labrum. So we've seen a dramatic decrease in the number of surgeries in overhead athletes, especially Major League Baseball. And we try to rehab them all, and we try to rehab all of the 55-year-olds that can present with that MRI in their hand complaining about the slap. And then some of the degenerative slaps, especially in slightly younger patients, but they're symptomatic, we try to rehab them. And then the tenodesis has been shown to be probably successful for most of those, or a release. So I'm asking the question now, is the slaps that we're operating on, are they the ones more likely with the posterior extension? Are we really treating the thrower and athlete with posterior instability with the slap, or is the slap that needs surgery still something different if it's not degenerative? Is it still instability in these younger throwers? Buddy, what do you want to say about that?
So I think that in younger patients, and then in our overhead athletes and in tennis players, the instability that occurs is symptomatic. I will still try rehabilitation first, like all of us. I'll do some steroids, some bracing, some taping, some good physical therapy. But what I tell the patient when I think they're unstable is that that about 2/3 are going to get better with rehabilitation and 1/3's not. And I don't know when you walk in the door which group you're in. But the ones that fail that good rehabilitation program over 4 to 6 weeks, those need to come to surgery. And I think what you're seeing is a true instability where you've lost that circle concept and the head's moving abnormally and producing symptoms. And no matter how good the therapist is, even Chuck, if they have an instability tracking pattern and it's not, you can't diminish their symptoms by centering the head on your exam, probably not going to work. Still give them a try, but it's probably not going to work. And so for me, those are people that I will fix and not leave alone, whether that's anterior extension or posterior extension. I think it's very important to fix them. The degenerative slaps is as you said, MRI scan says they're a slap tear. If a 50-year-old comes in and says, "Oh, I have a slap tear, I need surgery," it's like, no, you don't. That's every MRI shows a slap tear. It's just the way it looks. We're going to leave you alone, rehab you, you'll be fine.
Chuck, would you agree with my statement that the symptomatic slap in the thrower, we're talking younger patients, is a spectrum of posterior instability, or what is it?
I think for the ones that don't respond to rehab, yes. So I think that's why it's really important. I think Buddy glossed over such a key point in the exam of symptomatic, of what do we mean by symptom? Pain? Are you getting that click and sort of the instability or symptom of the labrum? They're two very different things, I think, in terms of what's driving the symptoms, in terms of what their primary complaint. Because I think what you begin to see, if it's pain, that usually resolves. It's not that big a deal. If they're feeling the shifting and the click is what makes them, it's an apprehensive thing. I think it is a type of instability. And then I think where Buddy kind of went through this very detailed exam to really understand how tight to return that shoulder to becomes important, because I think what we're beginning to understand is probably taking care of that posterior extension is fine, and just leaving enough of the envelope on top to provide the mobility that thrower needs is really the key to the whole thing. But I think really the understanding that exam piece. So for me, is pain versus some sort of apprehension of instability of their complaint. And then from my viewpoint, can I teach them to manage that with strength and motion or not? And either we get that under control pretty quick or we don't. And if we're not on that path, then I'm raising my hand, no mas, and getting them back to your office for other options, because especially in a situation like this, time is of the essence.
Thank you.
Can I just add something to that? I mean, you go back one slide. I think what you're talking about really is different. One forward. You're talking about different slaps, not just from the physical exam and the history, like Buddy and Chuck just said, but the first one is a type 2 slap. Second one is just a degenerative, maybe type 2, type 1 slap. And the posterior extension, it's a type 8, where it's really a slap tear superiorly and a Bankart posteriorly. And that's why you have more complex symptoms in terms of pain, clicking, and instability. So, I think even though the report may say slap, it's very different anatomic problems.
Thanks, John.
Heinz, the other thing is, I think it might be hard to lump in quote unquote posterior instability with this, because really what we're seeing is a posterior superior shift of the shoulder. It's obligate, it's posterior superior. You start with micro instability just with a slap tear, and it progresses with continuous instability. It's why we see extensive labral tears inferiorly. It's because they continue to progress, they continue to be unstable, and it goes inferiorly and posteriorly in an anterior instability issue. But this is probably posterior superior, more macro instability, not just micro instability in my mind. It's not what we call true posterior instability per se. I know it's all at the back, but that posterior instability of that 5 o'clock or 7 o'clock issue anatomically, it's all related really because the muscles are all tied in, but it's probably a little bit different. But yeah, this is a pretty significant anatomic lesion that at the end of the day, he's now having this instability issue, which is the key to tip you over for treatment.
Right. So that brings me to the question: are you going to operate on a 12 to 11 o'clock slap anymore? I mean, we used to fix anything that said a slap 20 years ago, but so are you operating on a 12 to 11? Does it have to go to 10 o'clock, or do you have a cutoff? Does anybody have any comments on that?
I think if they're unstable on exam and they fail rehabilitation, then you're basing it on the MRI scan. When I look in, if they peel back when we do an active movement test in surgery, then we'll fix it. The thing you're showing here with that posterior extension is very common in volleyball players. I see this a lot, in especially female volleyball players, where they have a slap. You can rehab them. You can work on their core. It keeps extending down the back as they play. And when it gets down to 9 o'clock, they can't play anymore. They can't spike. They can't hit. And so I see this extension kind of thing in volleyball players more. But I think if they're having symptomatic instability and they're unable to participate in their sports, I think you have to fix it wherever it is.
Matt, if you're going to repair him, are you going to lean towards more sutures, making it tighter, worrying less about gird or creating a posterior tension in a football quarterback than in a major league pitcher, or any pitcher, I should say?
Yeah, I mean, of course, we're very sport specific, maybe with even our surgery and titrations. You got to be really careful about that. But I'm always worried about losing internal rotation in a patient like this. And I don't care what sport you play, if you lose internal rotation, you're not going to like it. This I'm really, just what you did here is perfect. I think repairing the labrum, especially in a knotless fashion. I've had issues where knots have started, rubbing on the humerus, and now we've got some wonderful knotless options out there, and really focusing like you did on that starting posterior to the biceps and fixing it down to the equator. This patient should do very well, but I really try to get them moving very quickly and stretch this out so that they don't get that internal rotation issue. I don't care what sport they play, but of course we're even more cautious in that major league pitcher where I would be fixing just the labrum type tissue, not taking much capsule here. It's not needed. It's not stretched. That's not the issue. This is a chondrolabral containment issue, excuse me.
Would anybody do just horizontal mattress, or would everybody try to put something over the labrum to tuck it in, or do you want to just, some people say just do horizontal only. What do you have a preference?
No, I think this looks good. I think just as Matt said, anatomic repair of that labrum, and you know, again, since we have the knotless anchors, it looks great.
Buddy, how would you repair it? What configuration?
So the top part, I like the knotless anchors on the very top, because I always tried to minimize my knots to avoid the internal impingement. The further down, especially below that 3 to 9 o'clock, if it extends that far, I'm going to do a horizontal mattress and move the labrum up onto the face. But at that point, I'm trying to correct an instability as opposed to doing the chondral seal that Matt's talking about. So as long as we're sealing and it's a slap, I think the simple stitch with a knotless anchor is the best construct, because you're going to have less internal impingement. Once you have an anterior inferior, posterior inferior, or inferior instability, I think you really need to move the labrum up onto the face of the glenoid and create a better pattern, because that's disrupted.
So I want to ask everybody, when will you allow a quarterback to start throwing versus a baseball player? And when do you think he'll be able to be effective when for baseball as opposed to football, or is it the same? Start with Buddy, or I'll work down.
So for me, usually it's about 12 weeks we start our return to throw program. We have one for football. Now we have another one for baseball. We have a third one for baseball position players. We have a third one for catchers and a fourth one for pitchers. So it all starts at the same place at around 12 weeks, depending on scapula. I have started as early as 8 weeks because it just starts at 30 feet. And that Matt talked earlier about holding your patient accountable, but the patient, the coach, the parents, trainers, and therapists all have to be a part of this, so we never go past pain. But if they have good posture, good core, we've fixed everything else, then usually 12 weeks we start and we let them progress at whatever pace their body allows. But the goal would be 4 to 6 months having them back without restrictions.
John, quickly.
I don't think I can add much more to Buddy's program, only to add a few things. I think what's important is like sort of the psychological aspects, the psychological fitness, and, you know, where they are in terms of their career aspirations, and that may decelerate or accelerate the program. And, you know, obviously not forgetting about the rest of the kinetic chain, the lower extremities, back, and so on. Have him spend some quality time with Chuck to make sure that he's ready for all those stages.
Chuck, when will you throw?
I like everyone's program. I think really it's a matter of ramping, and so I love one of our surgeons talks about this is a big B-52, not a helicopter. So it's slow and easy is going to win the day. I would anticipate that between 5 and 6 months he can make 20, 30-yard throws pretty tight. For the longer throws, he's going to struggle. So I think it's interesting, actually, the power is what he's going to struggle with. So depending on the type of quarterback and kind of what he needs to do is really setting some clear expectations. But it's just a matter of reps and strength. So I think I love what you really laid out in the repair. This is an instability patient. This is not the slap patient with the cuff involvement and all the other stuff that sometimes you have to worry about. So I think as he gets into that, once he demonstrates that muscle performance, it's really about building his strength and endurance, but he's probably looking at a 3 to 6 month ramp in his performance. So I think you just have to set that expectation with the coaches. The biggest thing we see is these guys get into that 7-on-7 season. So let's pretend like we jumped in January and did it. He looks great in May. He's good in camp. He's doing 30, 40 throws a day. And then all of a sudden he jumps in 7-on-7s. And I'm just going to do a couple extra. So you got to put him on a pitch count. He's got to have a count and really a good recovery program that I alluded to early to allow him to be successful. And I think just understanding it's going to be a ramp in, and then, it depends how good he is, right? If he's an elite high school quarterback and plays on a average team, he's probably going to play. If he's a a high-level college or professional quarterback, he's probably going to be hanging out on the bench for a minute because he'll put his team at risk. But that's where it really comes back to some of the questions Buddy asked about our athletes at the beginning.
So he came back at 5 months and he's starting to have pain again. And the therapist here is excellent, looked at him and said, your scapula is frozen. You've learned to freeze your scapula. It is not moving. And he was creating an internal impingement every time just because he was posturing his scapula so rigidly against his chest. So we had to take a break. He'd been throwing high level, had to take a break, get things loosened up again, and then get him back into it. He's done well since that time. So I suppose just what you're talking about, that verbal at 5 months.
No, that's the classic thing, right? It's they do really well in a controlled setting, and whether it's a pitcher or in this case a quarterback, and we sort of let them go, and without very clear instruction and almost militant around what the expectations they're going to run into it. And I think just knowing that, hey, it's not the end of the world. And especially right, like in our pitchers and quarterbacks, they're 18 to 25-year-old males, and there's a reason they don't get car insurance at a cheaper rate until after 25 because they're not great decision makers. So honestly, my experience is you can tell them, and just setting that, hey, if you do this, you're going to be sore. And then that way, when it happens, it's a little bit of I told you so.
Hey, Matt, can you close this segment up for us?
Yeah, no, I mean, great case. It brings out some incredible features. I tell the coach 6 months, and the issue is we've got to get the athlete there, and mentally, this is a big game with them. Jan, you mentioned the mental side of this. We can work with it. Every day they're going to be on it. They're starting quarterback. They're thinking about this 24/7. I actually try to get a football in their hands as soon as possible because they're very nervous without a football in their hand. Now that might be light. That might be something super easy, but just to get them back and engaged and try to make it a scapula game. But I only let them do that with accountability. And if their scapula, if their scapula looks excellent, it's got to look good. They've got to push it. They've got to work hard because this posterior quote unquote instability problem is just that. They've got to work on their scapula. And this guy froze it up. He figured out how to do it too well, but didn't work the muscles dynamically. So you got to keep an eye on these guys and see them frequently in your office just to make sure their accountability is there.
Thanks, guys. Appreciate it.
Hi, I'm Jan Fronek, and just wanted to thank everyone to be able to participate in this discussion. It's always really a great, thoughtful, and knowledgeable group to review this information with. I wanted to tell you a little bit about the batter's shoulder, which is not a very common entity that we see in baseball. We've taken care of the baseball players in San Diego for a number of years, and this reflects a little bit about our experience. When we look at our pitchers and baseball players in general, the elbow and shoulder injuries take up most of our attention, and most of the shoulder injuries take place from pitching. But it's also, as we've discussed during this session, we're concerned about the labrum, the rotator cuff, the biceps tendon, and some of the pitchers presenting with shoulder instability problems. But all of this is related to the forces applied to the shoulder trying to throw a baseball. On the other hand, the hitting is obviously a critical part of the game as well. And some of the injuries to the shoulder that we see is on the hitting side. The two cases that I thought would be interesting to share with you go back a few years. This was a 30-year-old pitcher. He actually was hitting at this point. June 2011, had a pitch inside and had a subluxation episode that lasted about 20, 30 seconds. This is see if I can show it play. And basically what happened is you see this coming across like there. And with the hitting episode, basically experienced this marked pain with forward flexion, adduction, and internal rotation. And the instability testing was just as you see in this outline. Posterior was +2, anteriorly was trace and had a +1 sulcus sign. His overall range of motion was normal. And this is his MRI study. We did this one with contrast, and you can see how the posterior capsule is disrupted and some of the dye is leaking out between that capsule and the posterior glenoid. His rotator cuff itself was pretty unremarkable and didn't have much of a slap injury at all. So this was mid-season, June 2011, and he elected to proceed on with the non-operative program, relative rest, and then a pre-aggressive rehabilitation program. He was able to regain his range of motion, strength, and actually was able to get back to playing. Didn't modify his hitting that much, and August, later on in the season, had another episode, which ultimately led to surgical treatment. And this is what the intraoperative images look like. The humeral head's up here, and the posterior glenoid was stripped off. The capsule, the labrum was off probably from 9 o'clock all the way up to 12 o'clock, 1 o'clock position. And again, this was prior to the knotless anchors, and we were able to use the knotted anchors to repair this labrum back and the capsule. And so this was at the end, virtually at the end of the season for this pitcher. And by spring training, he was virtually without any symptoms, had a normal exam, and was able to play for the next 3-4 years. The other person is a little younger, 26-year-old, had a subluxation episode that reduced within 3 to 6 seconds. And upon questioning, he had a similar episode trying to play golf. So again, this is on the non-dominant side on the left shoulder. And it's really hard to tell on this, but he was able to, and you can see that he was not happy with this. And you can see just with this maximal adduction, internal rotation, the individual subluxes their shoulder back. And his exam was pretty similar to our previous picture. Basically, clinically had virtually normal range of motion, but the forward flexion, adduction, and internal rotation resulted in pain, had a little bit of a click. And again, the instability testing revealed that we could sublux him out back posteriorly, +2, anterior trace and sulcus sign was +1. This was a similar study with stripping of that posterior labrum and capsule off the back, and probably not as impressive as our previous patient. And this reflected basically more of a posterior inferior lesion rather than straight posterior one, posterior superior like our first case. And again, he had intermittent symptoms in September, and by October, he was completely tired and not happy with his current progress, and we decided to go ahead with the arthroscopy and labral repair. And again, if this is approximately 6 o'clock mark, this would be it's 9 o'clock mark all the way down to 6 o'clock, and posterior labral repair is what was our plan and what we carried out. And again, had the luxury of being off season, rehabbing, and by spring training had normal range of motion, no significant laxity that was present, and full participation at that point. So again, just to review some of the stuff that has to do with posterior instability, specifically for the batter's shoulder, and it happens with just non-dominant side usually non-dominant side for the right-handed hitters, and on the contralateral side for the left-handed athlete. And again, with adduction, internal rotation, and forward flexion, you stress out that posterior capsule and the labrum. Interestingly enough, most of these players will present more with pain rather than instability sensation. They may have the click or clicking, snapping sensation posteriorly. X-rays are not as helpful as the MRI. And then some of these individuals will respond to a good rehab program. But if they have persistent symptoms, particularly if the timing and their career is advantageous, arthroscopic stabilization is the way to go. Pretty unlikely that there would be a significant bony deficiency to even think about any type of bony augmentation, but that's always, I suppose, on the menu. The only paper that's really out there that deals with battered shoulder came out of HSS and Carl and Job Clinic. They combined their experience, two professional athletes and a variety of high school and college players. You can see different degrees of number of anchors that were utilized. And overall, the success rate in terms of getting back to competitive pitching and rather competitive hitting would be about 93%. Looking at other studies that look at posterior instability, this is lumping a variety of athletes, variety of sports together, everything from acute traumatic events to repetitive microtrauma to MDI patients to individuals with coronary hyperplasia. The results are sort of all over the board, everything from 67% to maybe 80% success rate in terms of getting back to sports. So it's just something to keep in mind in our baseball population. And I would open it up to questions. We can just talk a little bit about it. You know, in retrospect, Matt, what do you think about the location of the pain in these players, posterior instability specifically? Does that help, or is that more of a diffuse type of location of pain that you're interested in?
Yeah, you know, Jan, great presentations. I find these very fascinating because, and I'll get to the pain in a second, just because of how this may occur, being whether this could be repetitive microtrauma just from batting after batting after batting. How many swings do these guys take a year, and then something just tips them over the edge? Or is this truly just an acute injury that they were fine, they held it in, they had great scapula muscle control, they hid this for a while, and then something just tipped them over the edge and finally get those massive posterior tears? And those are not small tears. Those are very unique. They're kind of stripped off, almost posterior Perthes lesions. When you look at posterior instability, the number one complaint is pain. It's not really instability. We elicit instability on exam, whereas anterior instability is truly instability. We just published on this in AJSM where we had 100 anterior instabilities, 100 posterior instabilities, and the vast majority of posterior instabilities complained of pain. My shoulder doesn't work. I can't do it. I try. They can get through it. It's not like they're going to massively sublux or dislocate again. Sometimes they do, but for the most part, the shoulder's just not functioning well. They end up with pain. And probably do a variety of mechanical and other factors that shoulder is coming out posterior inferiorly.
So the location of the pain, I mean, I think of the medial meniscus, and patients can tell you this is where it hurts right there. But I find that the shoulder exam is not as precise. What do you think?
Yeah, no, I think, Jan, you know, that's exactly true. You know, just like we did in the prior case where that really posterior superior slap, there are some differences you can detect, and whether that's, you know, pain with shear or on exam. When we're talking about the player experiencing pain with their activities, it's really all over the place. It's hard to tell. It's posterior, but a lot of times it can radiate down the infraspinatus, then it goes down to the teres, then it's having these muscles that are working abnormally and are fatigued, and it's a fatigue pain or an ache or other things going on. There's a lot of stuff going on with this posterior component just because of the muscles that are back there, and I think that's where a lot of that pain's coming from.
Got it. Buddy, I think of you more as the shoulder whisperer, and your exam is pretty thoughtful. One little aspect of it, you know, we kind of try to grade the degree of laxity or translation in, you know, +1, +2, you know, over the equator, +3 locks out. Do you find that grading system helpful, or do you just try to compare it to the other side? Can you quantify it?
Sure. I think it's a little bit of both. For a batter's shoulder, it's basically crepitation on the back. When you do a KIM or load and shift, or even just a subluxation event, they'll have some crepitation. As Matt said, they don't really complain, and you said they don't really complain of instability. When you have a true posterior dislocation, you always have anterior injury as well. So posteriors that dislocate and have instability, they hurt when they flex, they've separated the rotator interval, or in many cases torn the coracohumeral ligament, and really lets that whole shoulder drop out the back and bottom. So that's the unstable posterior instability. And that's a whole different entity. Whereas a batter's shoulder, it's going to hurt with certain activities, primarily in the back, as Matt said. So it's been more specific to an area that this is abnormal. I don't feel right about it, but they don't really get the anterior pain that a true posterior shoulder instability will get. Occasionally they'll get a little pain on the biceps just from traction, but really that's about it. So it's that's why, like, you tried to rehab both of those, and we try to rehab most of ours. And I usually tell them that most of these come to surgery, but we'll try to rehab you, because it always happens, at the sort of the beginning or early part of the season. And then you want to try to get through that season if at all possible. And great results with your surgery, though. But that's my thought about the instability versus a batter's shoulder, which to my mind is an avulsion, but not an instability yet.
Right. Heinz, we got a question for you. Diagnostic imaging. Now, well, when it comes to the shoulder per se, we're sort of getting away from contrast, no contrast with the MRI. When would you get
for the overhead athletes? I still like the contrast MRI, arthrogram MRI, because it allows me to delineate it a little bit better. And it also picks up the Hegels a little better, although you have to watch carefully for artifactual Hegels or capsule tears.
Got it. Thanks. And Chuck, finally, we kind of talk about transitioning from rest to rehab to ultimately getting back to sport. Do you have a checklist in terms of when you allow your patients to transition to the next level, or how do you decide that they're ready to transition to the next phase?
So in some ways, it really comes back to where we started. I'm going to monitor their symptoms. They're absolutely not allowed to have pain, especially after surgery. That has to be gone. They have to restore normal motion, and they have to demonstrate the muscle function required for the activity. I think this is a particularly challenging case. So I make, for example, as I would take them back, they got to keep both hands on the bat as I take them into their soft toss and T program. And I won't let them come off the bat to single hand swings until after they're through fastballs. So I think really getting 6-8 weeks of really good aggressive swinging in before they start letting it go, because that's what's going to give them problem. And I want to get to kind of that 6+ month mark to really ensure that labrum is nice and healed down, because the challenge with these guys is they feel great at about 8-9 weeks. I mean, this is the classic instability patient. They're like, oh, I'm ready to roll. Let's go. You're like, whoa, wait a minute, big boy. So I think really ensuring that everybody's on the same page of what the progression is. And so the simplest way I found to do that is you can hit, but 2 hands on the bat.
Got it. Well, thank you very much. That was great. Really appreciate everyone's input.
Well, I want to thank all the presenters, just amazing presentations, and reflects a ton of work that all of these incredible contributors have done, and I'm very indebted to my panel. I just have a couple questions before we end the presentation. Chuck, when you're looking at an athlete that, say, plays overhead throwing, baseball, softball, you're measuring internal and external rotation, total arc of motion. Do you titrate their recovery or titrate their success and outcome by position? Like, I'm going to get this much internal rotation for a pitcher. I knew I need that at the end of the day, and we'll live with that. And this much external we're going to live with, versus a shortstop versus an outfielder or even a catcher. Tell us a little bit about your positional decision-making in terms of, let's just say, total arc of motion and rotation.
No, great question. Thanks, Matt. I think absolutely if I put them on ends of the spectrum, our pitcher is going to require the most total arc. They're going to require the most layback or external rotation. And then progressively, I'm willing to tolerate less internal rotation on that, folks. For me and our practice and kind of what my experience is, if they don't have 150, 155 degrees of total arc and at least 95 to 100 of external rotation, they're going to be in trouble. They just won't have enough layback without changing something else in their mechanics to get the velocity they need. I would include actually shortstops in my pitcher category. I think typically from the distance throws they need the same type of arm whip that a pitcher does. And then I think for the majority of our other infielders and outfielders, they tolerate a relatively normal range that, again, I'd like them to be 150. I'm not going to get too upset, but I'll let them be at 140 and maybe a more typical 100 degrees of external and 40 of internal. Quarterbacks and catchers are different beasts. They're built different. They have to tolerate different loads. Honestly, if they can throw without pain, I don't care. It's amazing. Just depending on their mechanism, they bring it from behind the ear and they throw a dart. Like, can you do what you need to do? And I'm okay. So I think really understanding there's that spectrum, but in general, quarterbacks and catchers are going to have a different, more body build, a little more stocky, a little more compact, and those guys, by definition, are going to have left motion. You've got to kind of have that expectation.
Great. Thank you, Chuck. So pitchers, shortstops, key, catchers, don't even pay attention. Just kidding. No, they've got other things to worry about. Catcher's a tough job. Believe me, I played it a little bit. Buddy, I got a question for you. The case of that posterior superior labrum slap thing, what athlete are you going to operate on earlier than later? Pitcher, volleyball, javelin, lifting, extreme athlete. Which one are you delaying the operation? Let's make the therapy work on this. And which one are you pulling the trigger on, just based on their sport?
Yeah, great question. For everybody, we always start off with rehabilitation. They're always dyskinetic. Most of them have core, not the wrestler and the weightlifter. Their core is usually really solid, good hip strength. So we start off and cover our basics. What I have found is my volleyball players, when that posterior labrum gets to 9 o'clock, when it gets to 9 o'clock, they can't play. So no matter how well I rehab them, I'm not going to get anywhere with them. Extreme sports, it depends. Mountain bikers can tolerate a lot of pain, so they're going to have to be really bad before you operate on them. And they're liable to have a fracture before you get to the labrum anyway. And so there's a lot of different things. I mean, you do a lot of the extreme skiers. I doubt they want to have their shoulder done. And if they do, they're back on the mountain so fast that you'll have a repeat customer. So, it changes. But for when it extends, if you just have that one little posterior superior part, you can rehab those for the most part and get them over it. But when it starts to extend down the back, volleyball players especially, I've not had good luck with them once it gets to 9 o'clock.
Great. Thanks, buddy. And I've got one more question to round out our session for our two San Diego colleagues. Jan, we'll start with you first. What do you think is the biggest unmet need in 2021 in regards to the overhead and throwing shoulder, and what's the take home for those that are listening to this talk?
I think that's great. I've got a laundry list of things here that I'd like to improve on. But I think what's critical, and I'm not sure that we have great solutions for, is for the high school and to some extent the college athletes that are treated, whether it's a good rehab program with or without surgical intervention, and then getting back to sport. And there, for our professional athletes, we've got the trainers, the therapists, the trainers, the pitching coaches, everybody guiding them virtually, ensuring their compliance is good day to day. But for the high school kids, especially, and to some extent the college kids, once they finish their rehab program, they're sort of, we give them some instructions and the therapist may instruct them. And then there's a gap, and some of that is filled in with private instructors, some of it is filled in with the coaching staff, but I think that's where some type of better guidance to continue that rehab program is really needed.
Great, thanks, Jan. So Heinz, give us the crystal ball. What are we going to see in the next 3 to 5 years in terms of the overhead throwing athlete?
I don't think we have to look forward. I just think we have to look back and see what's happened. And I would go back to it and say it again and keep it simple. For the adolescents, they need to play more than one sport or try to, and don't pick up a ball for 3 months. The pros don't pick up a ball for 3 months. They don't have to. And I think it's in their interest that they have growth plates that are even more sensitive than what the mature athletes are. That's it.
I love it. Start early and don't do too much. Early sports specialization. Well, gentlemen, I want to thank you all tonight for a great conference, a great session. Learned a ton. I hope you all did that are listening in on this. And we thank you for your participation in the San Diego Shoulder Course 2021. Thanks so much.